And today on ICMDA webinars, we've got Hedwin Kadrianto speaking on the subject of human trafficking in dental practice. So human trafficking in dental practice, you might think this is an unusual subject, but studies suggest that up to 87% of human trafficking victims interact with a healthcare professional, including dentists, whilst they are being actively trafficked. And if you're working as a dentist, you may encounter these patients in your practice presenting with dental pain, oral trauma, sexually transmitted infections, or other oral health concerns. And this webinar is aimed to equip you to identify and respond to potential trafficking victims, to recognize trauma triggers in the dental setting, and to implement a trauma-informed approach to dental care. Dr. Hedwin Kadrianto is an Indonesian dentist with postgraduate study in oral medicine. He was born again in 2007, and since then he's been involved in local and national student ministry through IFES and CMDF Indonesia. He's married to Ruth, a cardiologist, and they have 2 sons. In October 2016, Hedwin was appointed as an AEO, that's an Associate Executive Officer for ICMDA's Southeast Asia region for student and graduate ministry. And this was expanded to cover the Oceania region in 2020 and the East Asia region in 2022. Hedwin's interests are in the field of dentistry for people with HIV, including promoting equality of dental treatment access, anti-human trafficking, medical missions, networking, advocacy, and politics. Hedwin, it's a pleasure to have you here. You're a very familiar face to anyone involved with ICMDA, but many have not yet met you in your professional capacity. So we really look forward to hearing you speak on this hugely important subject and to interacting with you in Q&A afterwards. So over to you, brother. Thank you.
Great. Thank you so much for the wonderful privilege for me to share about this important topic. So if you're a dentist, like Peter have said, that there are a lot of possibility that you might encounter this kind of situation in the dental practice. So we will talk about how to identify and respond to victims of human trafficking in dental practice. And I really want to acknowledge this organization called Unbound Now, where I was part of this organization as a volunteer for around 4 years in Indonesia. And you can go to this website, unboundnow.org, and there are lots of training that I really was benefit from. And I really learned a lot from this organization in developing my understanding about human trafficking in medical and dental practice. So really want to make you familiar with this organization and that you can make use of their training. So let's go into the matter. So human trafficking, I think most of you know already about this topic. It's about recruitment, harboring, transporting, forcing, coercing, provision, or obtaining of a person for the purpose of involuntary servitude, debt bondage, or sexual exploitation. It's including the sale of another person's body or labor in exchange for something of value. I will go to the next slide so that it is clearer for you. So the action is including recruiting, harboring, transporting, providing, obtaining, patronizing, soliciting, and soliciting, especially in the sex trafficking, with means. I think the means is very important for us to differentiate between smuggling and trafficking. So the means is by force, by fraud, and by coercion. And the purpose can be for commercial sexual exploitation and can be for forced labor. So both kinds of trafficking can be found in dental practice. Both victims either for sexual trafficking or labor trafficking. But the means does not need to be present in a situation of sex trafficking of minors, usually below the 18 years old, where if they are involved in these two, commercial sex exploitation and forced labors, it's already defined as human trafficking because they are not allowed to make decision yet for themselves. So if they're involved in those practices, then it is already categorized as human trafficking. So the thing is that 87% of human trafficking survivors interacted with the healthcare professionals while they were being actively trafficked. So the experience of these trafficking victims shows that they actually visit a doctor or a dentist during the time where they were still victim or they were still actively trafficked. So most doctors and dentists, we do not care enough about this matter. We just want to get things done, treat the patient, and then just give the medicine, and that's all. While actually, we have the opportunity to see to save someone. Of course, we are not recommending you to, be the savior for the trafficking victims. That can happen in some cases, but majority, your role is really to ignite the hope and to let them know that there is a way out. But most of the time, we are not aware at all that, oh my gosh, this patient is actually a victim of human trafficking, and the trafficker is right beside the person in your clinic. Either you are a doctor or you are a dentist, you can encounter things like this in your practice. And because they can become sick, and when they are sick, they cannot perform what they have to perform, and the trafficker will bring them to doctor or dentist to usually for a quick fix so that they can go back to their business and they can do whatever they have to do. So the global reality we have, of course, the big, huge amount of human trafficking in the world. We have 40 million victims worldwide and $150 billion industry. This is the crazy, the dark part of our world today. Is you can see the statistics are like this. You can see the pornography business, the trafficking business is amazingly huge in many of these areas. In my country, in Indonesia, estimated 100,000 women and children trafficked annually. 1.2 million people temporarily trafficked, and 30% of females in commercial sex are under 18. So this is the reality, and your country is not immune to this, and you might need to be aware of the possibility of seeing these people in your practice. So labor trafficking, some of the predisposing factors that we need to be aware of is usually the immigration status, the recruitment debt, because usually when they were recruited, everything is told like very nicely, like everything is free, this is covered, that is covered, and they found out that actually that's a debt that they have to pay later. When we did the Unbound training, there is a commercial sex worker, the survivor, the trafficking survivor of sex trafficking, actually giving her testimony. So I'll just tell you a little bit of story about her. So she was a young female teenage in West Java, and then she was reading a job vacancy in the newspaper. So you can see this is like almost like a legal thing. So the advertisement for this job is found in the newspaper. So she came for the interview, and that she will work as a waiter in a restaurant in another island. So they give her the flight tickets, and then a group of people fetch her in the airport, and that's it, game over. She was brought into actually a sex trafficking business in a restaurant, in a cafe. Yes, that is true, but with the sex exploitation and sex trafficking that she needs to do, which she eventually later on came out of that successfully with the help of God, miraculously. But yeah, you can see that at first they tell her that the flights are covered, and then the transportation is covered, and then suddenly they found out that it is actually not covered. It's a debt. So that's the recruitment debt, and then people with economically disadvantaged, low levels of formal education, foreign nationals. So these are the possibility for people to get involved in labor trafficking. And this is the common characteristics among victims of sex trafficking: addiction, runaway homelessness. That's, how important for us parents really to make our house as comfortable, as happy as possible for our children, because people who are not happy at home, they are more prone to all kinds of dangers out there. So runaway homelessness, low self-esteem, history of physical and sexual abuse, family members or peers who are affiliated with gangs, low socioeconomic status, and identification as LGBTQ plus community. And the reality is really harsh. Victims are considered commodities by their traffickers. Buyers can be violent. Buyers, as customers, clients, are permitted to do whatever they want with this product. Thus, injuries are sustained, sometimes severe. Condoms are rarely used. Being moved around frequently can result in disorientation, not knowing city or address where they live now. Lack of preventive healthcare, vaccinations, dental care, health insurance, because the trafficker, they just want to make money out of these people, and they don't really care about these people. So for dentistry, they care about the front teeth aesthetically, but they don't care about the overall dental health, about the remaining roots and everything, all the infections. They don't care. They just want a nice front teeth looking aesthetically. No safety training, unsanitary fixes, focus on continued production versus health. So they really just want the pain to go free. They just want the front teeth to look good, and they really don't care about anything else. And lack of compliance with follow-up treatment or care. More than one half of the survivors reported dental problems, with tooth loss the most common problem. And many survivors reported that the cost of care was added to their debt burden. So whatever they have to pay in the dental clinic, in the medical clinic, they actually really have to pay it back to the trafficker. So this is a really terrible reality that they have to face. So the dental advantage, why you are the front line. So victims are highly restricted, yet dental emergencies, trauma, severe pain force traffickers to bring them to the clinics. And dental professionals possess a unique diastatic triad. The first one is unprecedented proximity. So dentists, we operate in the most intimate, vulnerable physical space, the head, neck, and the oral cavity, which is the primary targets of interpersonal violence. So we are dentists, really, we get in a very, very close position with the patient, all patient, but also in particularly in this case, the victims of trafficking. When we have extended duration, dental appointments last longer than standard medical triage. Usually the medical clinic, they just go in Indonesia, in a very, very busy clinic, you can just see the doctor in 3 minutes, 5 minutes, 7 minutes. But usually dental appointment, we have half an hour. When we do the cleaning, we have at least half an hour, 25 minutes, or even 1 hour appointment with the patient. So we can really interact more and more, and we can know more about the patient, offering extended observation time. And recurring access multi-visit treatment plans create a rare opportunity to build trust and spot behavioral patterns over weeks or months. Although sometimes when the pain is gone, they do not want to come back. But in maybe some rare circumstances, they do come back for the follow-up visit. So we need to read the room, especially the companion, the controlling companion, the trafficker, who may pose as boyfriends, uncles, employers, exert visible control in the clinical environment. So let's start to differentiate which is the supportive companion and which is the red flag handler. So the supportive companion allows the patient to answer medical history question, while the red flag one, usually they answers all clinical questions, physically interrupts the patient. So for example, a patient come to you with a broken front teeth, broken anterior teeth. And then as a dentist, we want to know whether someone punched you, or did you fell in the stairs or what. So we ask what happened to your front teeth. And then instead of this young lady, for example, answer the question, she actually look to her mother or her father or her uncle or her auntie or her whatever, like the trafficker. And then the trafficker will answer on behalf of her or him, because even we can see young boys also traffic. So the trafficker usually will, try to answer for this person. So, she is so very careless, so she fell down. But actually, it's actually not fell down. It's actually someone punched her at her face. So, and then for the next question, do you have any fever? And then she also again turn her head, and then someone will answer on behalf of her. So that's a red flag, because the patient does not have the independence to answer on her own behalf. And the supportive companion usually, the patient can hold their own documents. The patient holds their own ID, while the red flag handler, they hold the patient's ID, medical records, cash, everything, all documents, all money, and the worst, also their phone. Refuses to let the patient out of their sight, hovers near the dental chair. So, this trafficker, they do not want to let her go, do not want to leave the patient, and fills out all intake paperwork for an adult patient. And then the supportive companion, they can, they can just go out, they can just leave the patient comfortably with the doctor, with the operator. So, when we see someone really want to control, really want to cannot leave the person, that is also one red flag that might make us curious about what's going on here. And also, we want to recognize the dental phobia, recognizing the psychological trauma, because they might suffer from PTSD, post-traumatic stress disorder. So victims of severe interpersonal trauma and trafficking exhibit behaviors that mimic but distinctively differ from standard dental anxiety. So the standard dental anxiety, of course, we see a lot of anxious patients in the dental practice, a lot of patients who are tense, gripping armrests, but still responsive to surrounding. While in the trauma-induced dissociation, it's like a freezing. It's like the patients exhibit hyperarousal. They are physically tense, tightly gripping the armrest, but shutting down response. They may present with a blank, unresponsive state, and appearing mentally detached or miles away from the chair. And the communication, usually the normal patient, they ask questions about pain or procedures, will this hurt? But the traumatized one, the patient displays profound over-compliance and may repeatedly over-apologize, saying phrases like, "Oh, I'm sorry, please don't be mad." This stems from a conditioned survival strategy to really please the authority, really please the trafficker. Usually they want to please the trafficker. They don't want to be tortured. They don't want to be punched. They don't want to be hit. So they try to really over compliant or over apologizing. So that's another sign. Reaction to touch and position. The standard patient flinches predictably at direct pain stimuli, but generally tolerates routine, non-painful handling and positioning. While the traumatized one, the patient may exhibit severe flinching or a startle response, even at minor, completely non-painful touch. So even for very, very light touch, they can react very severely. Furthermore, they often experience an extreme fear of the supine position. The supine position was really terrifying for them. Being laid flat back can trigger a feeling of vulnerability and entrapment, and also flashback to the past abuse that they might have experienced. And the compliance, in the standard dental anxiety, they can follow instruction but may express reluctance. But the traumatized one, they can exhibit a form of robotic submission. They will really passively comply with every instruction without objection, while actively avoiding all eye contact with the dental provider. And in this case, then we need a trauma-informed approach for the patients. So maxillofacial, so now the clinical indicators, so that was the psychological indicators. So now the maxillofacial indicators of interpersonal violence. So we need to look beyond the tooth. Trafficking and physical abuse leave distinct geographical markers on the head and neck. So for example, number one is craniofacial trauma, unexplained maxillary or mandibular fractures, frequent temporal bruising. Number two, perioral soft tissue, lacerations, hematomas, scarring on the lips and commissures. That can be another sign. Dental avulsions, fractured, dislocated, missing anterior teeth with a clinical history that does not match the presentation. And then the neck and throat, finger mark bruising, ligature marks like strangulation signs, covered by inappropriate clothing, like for example scarves in the summer. Yeah, so this can be possible signs as well of interpersonal violence in the maxillofacial area. Now, let's go to the oral cavity and see the intraoral indicators of forced sexual exploitation. We can see a lot of specific mucosal presentations require a high index of suspicion, especially in minors or vulnerable adults. So the palatal trauma, viral or bacterial lesions, oral STD, and foreign bodies. I will go into a little bit of details of the picture. So these are fellatio-associated erythema of soft palate because of forced oral sex. So you can see the erythema here, which actually the good news is they can subside in like 2 weeks, 1 or 2 weeks, they can like heal automatically. But in some severe case, you can see the erythema and petechia is like wider in the palatal mucosa. And it is actually a bit similar to blood dyscrasia, like blood disorders, so like hemophilia or leukemia. So sometimes in a case like this, we have to do the blood test, the complete blood test to rule out the possibility of leukemia, the possibility of like thrombocytopenia, low platelet count, because the outcome of the trauma from fellatio can be something like this. And then we can see a lot of like oral sex related infections. So chlamydia, gonorrhea, this is usually the classic oral sexual transmitted infections that might happen. And for these two diseases, just a refreshment for you. I think most of you knows about all these things, but to refresh your mind, usually they are in the posterior, in the tonsillar area. You can see like the whitish, yellowish exudate here, and it's usually causing like a sore throat and then painful in swallowing, infection in the tonsillar area. Usually not much happening in the oral cavity, but when you see the tonsil area, you can see all these kinds of whitish, yellowish exudate. And the herpes infection, usually it starts with a blister, usually accompanied with fever, and usually it can rupture. And then the difference with the normal ulcer is that the irregularity of the ulcers. So you see the irregularity, and then combined with the erythema near the ulcers. And you can see usually it's in the keratinized mucosa like the tongue and then the hard palate and also the gingiva. So this is the herpes infection. Usually the more dominant one in oral sex is HSV, the herpes simplex virus 2 instead of 1. And you can do the lab test with the IgG, the IgM, those things. And this is the human papillomavirus infection. You can see lots of kinds of lesions like squamous papilloma, and then focal epithelial hyperplasia, and then verruca vulgaris, and then condyloma. So all these things are human papillomavirus infections. So all these lumps and bumps that are irregular like this, and with a history of oral sex, we can suspect things like oral sex history, but you need also combine with all the other red flags that we have discussed earlier. And I will not go into details of the treatment, but we can do it in the Q&A if you want to know more. So the syphilis, this is the primary syphilis. It's usually a deep, single irregular ulcer with a yellowish base. So this is the primary chancre of oral syphilis. And I give you more pictures of the secondary syphilis, where we see the mucus patch with the yellowish exudate. So these things are the manifestation of oral syphilis. And the third one is the severe one, where you can see the perforation from one cavity to another, and it's called gumma or gamma. So this is the severe phase of syphilis. And then you can see also here in the near the navel, you can see the maculopapular rash of syphilis that is quite classical for the secondary type of syphilis. And then you may see also the other kinds of oral manifestation associated with HIV. So I think HIV test is very, very useful in this particular situation. And we can see things like oral. I think I just go with this lesion strongly associated with HIV infections, oral candidiasis, oral hairy leukoplakia, Kaposi sarcoma, non-Hodgkin lymphoma, and acute necrotizing ulcerative gingivitis. So all these kinds of oral manifestations are very, very typical of HIV. But of course, you can see the other oral manifestations. If you are not sure about all these things, you can, of course, refer to oral medicine or oral pathologist or even oral surgeon in your area so that they can know the right diagnosis, of course. But having said that, in the trafficking case, they really want the quick fix. But of course, you also have the right to refer if you are not not confident in treating this disease. So the clinical signature of severe neglect also, because of the cramped living conditions, the sleep deprivation, severe dehydration, and zero preventive care. So you can see severe aphthous ulcers as a sign of systemic malnutrition, angular cheilitis, and oral signs of nutritional deficiencies. And then you can see untreated odontogenic infections, multiple abscess, and advanced periodontal disease in young patients. And then stress and substance abuse, severe bruxism, attrition, meth mouth decay, and then acute necrotizing ulcerative gingivitis. The quick fix, they just want the cheapest option and then the quickest option as well. This is the meth mouth. You can notice the rampant cervical caries here, and also the acute necrotizing ulcerative gingivitis here. And the operatory is a triggering environment. So while all the dental problems, the fracture, maybe the laceration and everything, the hematoma, and when we want to treat them and the patients start to sit in the dental chair, the dental operatory can trigger many things in their mind. So the first one is the power dynamic. The patient is supine, physically immobilized, and positioned below the provider. So all these things are very stressful for the patient, and it can really make them flashback with all the trauma that they have experienced. So later on we will discuss about the trauma-informed care, but let's see about this. The invasion of space. You can see sharp objects, hands, fluids are introduced into the mouth, a highly sensitive and potentially traumatized cavity. So the power dynamic, the invasion of space, sensory overload, the overhead lights, the loud high-speed drills, and sudden movements induce panic. So what I really like to do now, just for my normal patient, I always put a soft Christian music. So just really to make me calm and make my patient calm. So that's what I love to do when I clean. I do the scaling, the cleaning, or the filling. I just make, put a soft music, instrumental music that really can ease the patient's fear and anxiety. And loss of voice, the use of bite blocks, rubber dams, and instrument prevents the patient from speaking or crying out. So you can imagine the stressful situation in the dental operatory. This is all like can trigger the trauma and the stress. So that's why we want to introduce you to trauma-informed dental care. And this is a clinical framework designed to deliver essential care without inducing re-traumatization. It shifts the provider's mindset from what is wrong with you to what happened to you. So the first one is realize, understand the widespread impact of trauma, understand the potential paths of recovery, recognize, actively look for the signs and symptoms of trauma in patients, companions, and even staff. And respond, fully integrate trauma-informed knowledge into your clinic's policies, procedures, and daily practices. And resist re-traumatization. Actively avoid triggering practices. Do not interrogate. Do not force sudden touch. So let's look a little bit more into the trauma-informed dental care environmental control blueprint and the safe, creating a safe environment for the patient. So the instrument, let's keep trays covered with a sterile drape until the patient is seated and ready. Avoid flashing sharp objects. So you might need to hide your needles, your injections, things like that, or the pliers and the excavators, and all those scary objects. We might need to hide them for a while, and then the chair angle, ask permission before reclining the chair. Allow the patient to remain semi-upright if requested. So I think we can also work with semi-upright positions. So I think that will be more comfortable to the patient. The stop signal, establish physical control. Tell the patient to raise their left hand if they need you to stop immediately. So of course, they cannot speak while all the instruments are in the mouth, but they can definitely raise their hand. The screens, change overhead TVs from anxiety-inducing news channels to calming, neutral visuals. Put on music. Of course, do not put on the CNN, the BBC, all the crazy news about wars that will really make the patients even more anxious. The mask. Before you put on the mask, introduce yourself and converse briefly before putting on your mask and loops to establish human connection. We understand that some patient can have like tuberculosis and some things like that. So, the triage in the nurse with the nurse, all the initial interview in the reception will be important for you to determine whether you want to put off your mask before you put it on, just to give a friendly gesture to the patient. And then, sometimes we need to ask very sensitive question and we need to separate the victim from the trafficker. So you cannot screen the victim if the trafficker is in the room. So you must separate them without raising the trafficker's suspicion, which could endanger the victim later. So try to separate them. So for example, we can, make reason like the aerosol protocol. So, we want to do some aerosol thing and the companion need to be out of the room. So for example, this is like COVID-19 standard protocol that we have developed in our clinic. This is a non-negotiable clinic policy. So you need, the companion needs to be out of the room. Or maybe we can have a script in the front desk assistant for health and safety regulations regarding aerosol generating procedures. All companions must wait in the reception area. Thank you for understanding. So things like this. And also we can send a companion to the front desk to handle complex paperwork or utilize the X-ray room. So this is a very brilliant idea. We can go to the X-ray room and put the patient in the X-ray room. And then, it's only one person allowed, the patient and the X-ray, operator. And, in that particular room, we can ask many, many things to the patient, which some of us in Indonesia, we have done this thing. And then we have gained very, very sensitive information actually in the X-ray room. So we want to do the screening. Now we are in the safe room, just two of us, just the dentist and just the victim without the trafficker. So once alone in a private, secure space, use simple, direct language. Use the patient's own terminology. Do not correct their phrasing. What kind of work do you do? Do you have a manager or someone who controls your work? And then the safety question, has anyone ever forced you to do things you didn't want to do to pay off a debt or in exchange for food, shelter, or drugs? And for minors, has a boyfriend or anyone else ever asked or forced you to have sex with other people? And then if disclosure occurs, validate immediately, I believe you. You are in a safe place and your medical information is confidential. So this is what we say when we have heard a very, very sensitive information. And then what else we need to do? Documentation, building the lifeline. If you suspect abuse but the patient denies it, your clinic documentation may serve as critical evidence for future legal or social rescue efforts. So do not write, patient is a trafficking victim. Do not do that. Write objective facts. Patient presented with 3 centimeter laceration on lower lip. Companion refused to leave the room. Patient flinched severely upon palpation. So, you can write objective things like this. And then clinical photography, take comprehensive, well-lit intraoral and extraoral photographs of all trauma. Ensure dates and times are stamped. And then use quotation marks for exactly what they say. For example, patient stated, I fell down the stairs. And age estimation for undocumented minors, note dental eruption patterns. Third molars to assist law enforcement in age verification, because in many countries, unfortunately, including Indonesia, sometimes people can give bribery and then they can make a falsified ID card. So sometimes dentists can identify wrong ID card. For example, the dentition is like just maybe 15 or 16-year-old, but the ID card mentioned is like 20 or 21-year-old age. So, we sometimes we cannot trust the ID card, and we trust more the dentition and the third molar situation of the oral cavity. ICD-10 coding is very good. All the maybe ICD-10 coding for HIV and those stuff, but you need to be more familiar with the ICD-10 code for suspicion of human trafficking. So you can see this suspected exploitations is T76.51 for adult and 52 for child sexual exploitation. And labor exploitation also 6162, and confirmed exploitation is another code T74, and then the clinical examination Z0481, encounter for examination and observation of victim following forced sexual exploitation. So offer referral, never force. So we do not want to be the savior for the patient, but we can ignite hope. We plant the seed. Offer the referral securely. Memorize a hotline number. In Indonesia, we have very, very easy number to memorize for the patient. This might be tricky, right on inside the lip balm cap or discrete piece of paper, because if the trafficker finds out about the paper, they can, make some harmful thing to the victim. So we have to be very careful on giving out paper. If they decline help, respect their choice. Focus on providing excellent trauma-informed dental care so they view your clinic as a safe haven to return to. And the minor exception, under some countries' regulations, suspected abuse or trafficking of an individual under 18 must be reported to local law enforcement. So how to do that? You need to be prepared before it happens. So the see, shift, and shield. See the shadows, look past the chief complaint, identify the controlling companion, the physical markers of trauma, and the psychological freeze response. Shift the environment, the 4R for the trauma-informed dental care, and shield the patient. Isolate the patient, if we can separate, ask direct non-judgmental questions, chart objective evidence, and provide discrete paths to freedom. And this is maybe a helpful resources for you, globalmodernslavery.org, GMSD, and then you need to set up protocol and connect with relevant local resources before that kind of situation happen. You might need to know what is the National Human Trafficking Hotline Directory in your country. What are the trauma-informed emergency shelters available in your country? The legal aid clinics, national or local anti-trafficking coalition or task force or friend that are involved in this ministry, International Organization for Migration, major tertiary university hospital, the social work unit or the forensic team, and faith-based medical network. This is another helpline directory for many countries, humanityconsultancy.com. And this is Hill Trafficking. So I stop here and let's continue in Q&A.
Thank you so much, Hedwin. That's really fascinating, deeply disturbing, and very comprehensive. And I'm sure that this is making an impact and bringing things to mind for a lot of the people who are listening as well. And a lot of what you've said is relevant not just for dentistry, of course, but for identifying trafficking for other healthcare professionals as well. And I, for one, had not really considered some of the things that you've raised, like the fact that you're with the patient so long, that you're dealing with a very vulnerable part of the body. And so that gives a great opportunity for dentists, but also an awesome responsibility, I think, as well in this whole area. So we've got a time for question and answer now. But I wanted to ask you first, Hedwin, your experiences in Indonesia, but you've been interested in this for other countries as well. And I just wondered, you said at the beginning these actions are crimes. Is that true in all countries? Does it depend upon the country we're talking about? How robust are the legal safeguards for bringing these cases to police attention, for example?
Yeah, of course, we cannot always directly call the police at a situation like this because, we might have a threat from the trafficker. However, in one situation in Indonesia, just want to tell you an experience that it happened in a hospital, actually. So they successfully isolate the patient. The patient was hospitalized. Actually, she was not need to be hospitalized, but she was hospitalized. And actually, they call a police and the police arrest the trafficker. So that actually already happened in a hospital in Indonesia. Part of our team actually shared this experience. So the legal framework is really depend on every country. I think you need to know what is the anti-trafficking laws in your country. We are aware of the anti-trafficking laws in Indonesia, and it's actually basically the same with what we have seen in the definition slide, that is actually crime. So, of course, there is slightly different between the category of crime for minors below age 18 and for the adult. So I think we need to be aware of that, and we need to, if possible, and if we feel it is safe for the clinic, for yourself, and for the patient to, call the police. But what I suggest you to do is not to make that decision now, but really to plan a talk or a discussion with legal aid clinic or an anti-trafficking activist in your area, an NGO. So if you can, have a talk with them, have a discussion with them, either legal aid clinic or either anti-trafficking NGO or activist, then discuss with them what is the best thing to do. If you recognize someone, if you see things like this, and build a protocol, because it can be very, very different from one country to another. What is safe, what is not safe, what is lawful and what is not lawful, and so I think the best person to inform you is the local anti-trafficking activist or coalition.
That's interesting. As you say, it's easier if the victim is an inpatient, where you've got the protection of the hospital, the staff, the building, and so on. But I guess, given the nature of dentistry, most of your encounters are going to be at outpatient clinics or mobile clinics, when you may only see the patient once. They may be coming in for a one-off. So in situations like that, where you have a very high index of suspicion about trafficking, what can you do? I mean, you've talked about the dentists being really not so much rescuing the patient, but actually making it more likely that they will be rescued by others. So what would for the one-off encounter, which I would suspect is going to be the majority of cases.
Yeah. Number one, you need to give the hope to the patient. Let her know or let him know that there is a way out. Inform them about website or NGO or a hotline number that is very easy to remember for the patient. For example, in Indonesia, it's like 129. So, if we give this number of or website or NGO to the patient might remember, oh, okay, if I have the opportunity, I will call this number, or I can go out, I can be rescued by this means. Number two, after the patient leaves the clinic, then you need to call the police, or you need to call, and you need to really document very, very carefully everything. So the case, and then the lesion, and then all the medical records, but also the documentation like the ID card of the companion, if possible, also the ID card of the person. Of course, we might lose track of the person, or maybe it is too late. The other possibility is also you can call an NGO, or your network or anti-trafficking while the patient is still inside, or while you are still suspecting. So, but at least if you call them while they are there or after they are there, at least the authorities knows, and can be aware of the possible situation, and maybe they can do something to track. But at least the least that we can do is really to let them know that there is a way out. That's why the protocol needs to be defined before it happened.
Now, some of these traffickers we know are pretty desperate people, pretty violent people as well. And what about dangers to the dentist themselves for getting involved? Some people might be reluctant because of what it might mean for them personally. What can dentists do to mitigate against that kind of violence directed towards them? And any other advice as to what you do in that situation?
Yeah, I think this is related to the previous question, that we not in every situation we supposed to make a police report and everything. So the best thing that we can do is really to really collaborate with the local anti-trafficking NGO, and just to make them aware of the situation. And if you really compelled to call police, I think you really need to assess the safety first, because we do not want another group to suddenly burn the clinic on fire or whatever thing. So we really want to assess the situation. Usually in our training, if the dentists are not ready with reporting to the police, we totally understand, and we do not want to push the dentists to do that, because of the harmful risk that they might get. So what we really suggest is really to talk to the local anti-trafficking network, and to build partnership with them. Mention that you have a concern, and maybe you have heard the webinar and you have a concern about this area, and they usually know better what to do according to the local context and situation. Yeah. So really, I think one of the key thing is collaboration with the local anti-trafficking movement that is in your area.
Now, there's one question here about the relative commonness of this in different countries as well. Any comments on that? Are there any countries where this is much, much more common than others? And can you point us to any data about the prevalence in different countries?
I don't have any data about the prevalence, but what I can give to you is that statistics of 87% of the survivors. So this survey was not done for, it's of course very difficult to do research in this area, but for the survivors, more than 80% mentioned that they actually visit a dentist or a doctor during the time when they were trafficked. So we also asked our friend who survived the sex trafficking, and she said, yes, that's true. In her case, it was a gynecology clinic. Because someone left the because of the menstruation, and they were forced to do sex work during the menstruation. So someone like put something inside, and then infection and so on. So and so people were brought to the gynecology clinic during they were trafficked actually. So yeah, I'm sorry, I do not have the data, but for my own experience, I actually experienced many times seeing patients with oral sexual infections. But of course, in those circumstances, I think the closest one is actually an active commercial sex worker with the client, actually. So, but it's actually in the at that time I was not so yet trained well in this matter. So I was a bit regretting that at that time I was not so aware about all these things. So yeah, it happened. So it's the guy was from Middle East, so a foreigner from the Middle East, and then the victim, or the it's like the suspected commercial sex worker. So they come together, and it seems like the girl was like not forced into it, like they are like enjoying themselves at that time. Looks like looks like absolutely happy and like very cheerful. But I found lots of things inside the mouth, and I think that was more to the client instead of like the trafficker. So I think the situation was a bit different.
So there is heightened awareness about trafficking. There is still a lot of ignorance as well. But have you noticed in the literature or personally that victims are more likely to signal for help now than they were, say, 10 years ago? Or is it?
Yeah, if you know the Stockholm syndrome developed where actually the trafficker become used to it. Sorry, the victim become used to it. They do not have any other alternative of life. They just know that kind of life, and they become used to the slavery. They become used to the exploitation, and they do not have an alternative. So sometimes that happen, and that really complicates the diagnosis and the identification, and they usually refuse even to be helped, which is fine. We cannot do anything about that. So I think people are now more aware. I think anti-trafficking activities in the world is really growing a lot, I think, in the last 10, 20 years. Of course, yeah. Having said that, it's always, I think, like 50-50 between people who really want to out of that and people who already like be used to it and, just surrender to whatever the situation is. So I think whatever the situation is, it's very good for us to share that, you can go out of this. There is a way out of this. There is a hope, and there are some group of people that can help you out of this situation. Which it's a seed in their mind that maybe one day when they're becoming more frustrated with the suffering and everything, hopefully they remember those hints that you have given in that situation.
Yeah, fascinating. And just finally, Hedwin, because we're running out of time, I wonder if you could just share a little bit about your own journey with this whole issue. What got you interested in it? What motivates you to carry on? And how did you get help to be trained to be as aware and capable of dealing with it? Because others may well be interested.
Yeah. So, I was first interested in human trafficking because of ICMD webinar. So I still remember very well. I watched the ICMDA webinar of Dr. Catherine Welch, and she was
Yes.
the founder of Relentless. Since that,
Yeah.
I constantly thinking about it. And then I met another group in Indonesia, Dr. Debbie, that also led the human trafficking special interest group in ICMDA. So I met her, I met the other group of people, and actually they want to collaborate with CMDF Indonesia about, training Indonesian doctors about anti-human trafficking training and materials. So I said, well, I mean, I do not just want to connect you, but I want to be involved as well. Is it possible for me to be involved as well as a trainer in this area? And and then she was connecting us to Unbound Indonesia at that time. It's from the
Yeah.
U.S. organization. So I think in ICMDA we have a group of anti-trafficking network. So if you're interested to be part of this issue, I think you may need to. I think we will, develop the special interest group page also in ICMDA. And if you're
Yeah.
interested later in the anti-trafficking movements and you want to be trained, I think you can definitely contact the contact person, and then we will create this kind of training for you. But for now, at least you can connect to the CMDA network in your country, which might be connected to the wider anti-trafficking. I think CMDA is doing very well with this. CMDA have their anti-trafficking
In the US.
in the US. And also us in Indonesia, we have anti-trafficking group also that is very active in, doing seminars for doctors and dentists. And also we actually, the anti-trafficking group in CMDF Indonesia, they also go to schools and churches to share about these things. So there are lots of materials like social media safety, and then about finding job in a foreign country, and also about pornography. So there are lots of beautiful materials that I hope CMDA doctors and dentists can be the trainer. So you can go to your schools, your churches in your area, and also you can talk to doctors and dentists in your area about this matter. I think it's very important more people will be involved in this ministry.
Yeah, absolutely. And thanks for making us so more aware of it and better informed today. There's just one final, very brief question. Someone's asking, the ICD-10 codes are applicable in every country, aren't they? Someone's asking. It's an international code. Yeah,
Yes,
that's right.
Yes.
So thanks, Hedwin, so much for sharing with us your expertise and your passion too for making a real difference in this area. It's been really clear and encouraging. May the Lord bless you. Thank you.